So how are we leading the future and innovating for better healthcare? Discover St Vincent's, the new podcast, proudly brought to you by St Vincent's Curran Foundation, uncovers and discovers groundbreaking innovation and research. To ensure St Vincent's hospitals continue to provide world-class healthcare, foster excellence and innovation in patient health and medical research, we rely on support from people like you. Go to supportstvincents.com.au to find out more and make a life-changing difference today. Welcome to Discover St Vincent's, a podcast leading the future and innovating for better healthcare. In this show, we will uncover and discover some of the groundbreaking innovation and research at St Vincent's Hospital, Sydney. I'm your host, Zoe Callister-Hakewell, a health innovation specialist. Today, we'll be exploring a topic that's crucial to our overall health, yet often overlooked: gastrointestinal health. We'll unravel the complexities of conditions like IBS and IBD and discuss groundbreaking treatments and hear personal stories from those receiving treatment at St Vincent's. We'll be speaking with Associate Professor Craig Heifer, a renowned Sydney-based gastroenterologist at the forefront of using the gut microbiome to treat gastrointestinal illnesses. He has been instrumental in pioneering fecal microbiota transplantation.
There's that link and there's that constant talk between the immune system, recognition of what's there, trying to some control over what's happening in your gut and vice versa. That's what we all refer to as the microbiome.
His work is not just changing lives, it's also shaping the future of gastroenterology. We'll also hear from Dr. Simon Garley, a distinguished gastroenterologist who leads the Inflammatory Bowel Disease Clinic at St Vincent's Hospital, Sydney. His insights into Crohn's disease, ulcerative colitis, and the latest advancements in IBD treatment are not just informative, but also inspiring and transformative to patients' lives.
Something we've been running at St Vincent's since 2019, had the support of the foundation in getting our first machine, and we've now got a second mobile machine that we can use for outreach to regional New South Wales.
And we'll also hear from a patient, Annabelle Rogers, who brings a personal perspective to our discussion. As a patient treated at St Vincent's Hospital, Sydney for ulcerative colitis, her story is a testament to the power of modern medicine on treating lifelong gastrointestinal diseases.
I just remember waking up from the colonoscopy and the gastroenterologist saying, something doesn't look quite right, we've sent it off for tests. I was like, oh cool, he must just mean like the picture wasn't good.
Yeah.
Completely oblivious to everything. And then I went in for a follow-up appointment and I just remember him saying, you have ulcerative colitis. And I went, what does that mean?
So get ready for an insightful journey into the world of gut health. Have you ever considered the power of the gut microbiome in treating complex gastrointestinal diseases? And what about the role your gut microbiome plays on your mental health? By the end of 2030, almost 1% of the population are expected to have a form of Crohn's disease, ulcerative colitis. Today, we delve into some of these questions and more with Associate Professor Craig Heifer. Associate Professor Heifer is an absolute pioneer in fecal microbiota transplantation. But what common myths about IBD and IBS will he dispel? And how does this research redefine our understanding of these conditions? Prepare for a revealing conversation that will alter how we view and manage these complex disorders.
So I'm Craig Heifer. I'm a gastroenterologist and academic at St Vincent's Hospital and University of New South Wales. That's looking after patients with Crohn's disease and ulcerative colitis, which is an inflammatory disease. So it's a disease that's caused by someone's immune system playing up and seeing something in their tummy as not quite right, shouldn't be there. And so your body's immune system goes and attacks your own tummy, your own bowel. And so it causes a whole lot of different troubles. And we look at these patients and we manage these patients and see whether we can improve that inflammation, improve their life.
That's a really good explanation.
So there's a big difference with IBD and IBS.
Yes.
And
What is it?
so inflammatory bowel disease,
Yeah.
that is Crohn's disease, ulcerative colitis are the main terms that people may recognise or understand, and that's where your body's immune system causes inflammation in the bowel.
Yeah.
Irritable bowel, it's a terrible term. It's IBS. It's often been a term to use as a bit of a throwaway, saying, hey, look, there's no inflammation, there's nothing wrong inside the bowel. It's a condition where people have significant symptoms of their tummy. So they can have bloating, they can have discomfort, they can have diarrhea, they can have constipation. IBS is this umbrella term, and there's so many different subtypes of IBS. So up to 40% of the Australian population will have some form of irritable bowel.
Yeah, wow. That's so common.
Yeah, it's really common.
Almost
and
half.
Exactly. And when it starts having a big impact on someone's life, that's when it starts becoming IBS as opposed to just a bit of irritability or a bit of those nervous poos that people get. I'll often say to patients, if you had a magic wand that could make over one of the symptoms, what would it be?
Yeah.
And based on that answer, I'll guide the therapy trying to manage that symptom. Where that's quite different to IBS, where our therapies don't impact the immune system at all. But we also know that almost 60% of people with Crohn's disease or ulcerative colitis will have both IBS and IBD.
Really?
So concurrently, they'll still get a lot of the symptoms that people with IBS will have.
Yeah.
And we have to manage both of them. So we manage the inflammation, but we also manage the symptoms, particularly that are left over after treating the inflammation.
So what are the types of patients that you get, or who is most susceptible to these types of conditions?
Yeah, so Crohn's disease, ulcerative colitis classically will affect younger populations. So previously, the main peak we saw was aged 18 to 24. There are, of course, young kids that get it, that get this condition that are often managed by the Children's Hospital and will get transitioned to our service.
Yeah.
Now we're seeing this second peak of people suddenly developing the disease in their 50s, 60s, even 70s and 80s, suddenly for the first time developing Crohn's disease or ulcerative colitis.
Why is that?
We don't quite know. It's a really complex what drives and what causes and what triggers inflammation, but we know there's something with the immune system, there's something with the environment, and that link is somewhere probably within your gut microbiome, all this gut bacteria and organisms that sit within your gut that talk and trigger that immune system.
So I want to ask you a little bit about the gut and mind connection that you mentioned. A lot of research coming out about mental health being intimately linked with your gut. Can you expand and explain that connection?
Yeah. So I guess it's probably worth taking a step back and saying, when we say the gut, what do we mean by the gut? And when people talk about the link between the gut and whether it be mental health, whether it be joint diseases, lung disease, anything else, they're really referring to the gut microbiome. And really the microbiome refers to this whole ecosystem of different organisms. That's bacteria, viruses, fungi that all live in harmony. There's billions of different organisms that live in harmony in your gut. And they will fluctuate over time and they get influenced by everything on the outside world. So the food that you eat, exercise, where you live, medications, other diseases will all have an impact on your gut microbiome. And when that changes, we know your gut microbiome is really that link between the outside world and the inside world because it sits there in the gut. We thought it was separate, but really we know that there's constant crosstalk between your microbiome and the inside of your body. And there's lots of different terms that come up, but really there's that link and there's that constant talk between the immune system, recognition of what's there, trying to some control over what's happening in your gut and vice versa. And so that's what we all refer to as the microbiome. And so we know that in mental health as well as with other conditions that there's more and more evidence to show that there's some sort of imbalance in your microbiome that is associated with the development of various mental health diseases, including something like depression.
Wow.
And it can be a little bit of a crosstalk. So there's a lot of debate whether these things are a chicken or the egg. And this happened with Crohn's disease, happened with ulcerative colitis. It's happening in the cancer space as well. And so they say, well, is the microbiome driving what's going on? Or is whatever's happening on the outside world driving the changes in the microbiome? And there's usually this bit of a argument that goes on.
Yeah, right. Wow. I didn't realise that there was a significant sort of trigger or change that could then kind of unlock a condition like depression.
Yeah. Again, with depression and mental health, there's more data coming through.
Yeah.
And again, the link is not fully understood, but that's really the overview of where it's heading. And what's really exciting about it, it's not so much about it's also understanding about what's there, but saying, well, can we unlock some sort of therapy that targets the gut to treat various illnesses? And a really nice example of it is, we know most people have heard of the FODMAP diet that changes your diet, that will improve your tummy symptoms. There's some more work gone into what's called gut hypnotherapy. The easiest way, it brings in a number of different techniques. So it brings in a bit of mindfulness, a bit of meditation, and a more repetitive type, I guess the term is repetitive thinking, to recognize what's happening in your tummy and to remove the trigger or the sensitivities around, say, symptoms in your tummy. So it's specifically targeted to the gut for gut chemotherapy. And it's a program that people do themselves every day, 15, 20 minutes for 6 to 8 weeks. Previously, you had to go to a psychologist to do it. Now there's apps and other things that people can do. And the data is really clear. It shows it works as well as a FODMAP diet, something that someone do yourself, like without taking a medicine, they do themselves, and it works really nicely. And we use it regularly in clinical practice.
Yeah, I feel like we fall back a lot on medications first and foremost. Currently in our society, because we want everything now.
Something quick and easy.
Even a program over 6 to 8 weeks, that's relatively quick to complete. That's really interesting. So I guess you also have the role for a psychologist then in amongst all this gut gastroenterology kind of area. That's really interesting.
We have to think about what the disease can have on someone's life. It's often these silent, these invisible diseases. No one likes to talk about poo. So like we know with Crohn's disease, 1% of the population by the end of 2030 are expected to have a form of Crohn's disease, ulcerative colitis. And if you think about that, that's very common. These are people we work with that you probably don't even know that they've got it. We've looked after athletes, we've looked at politicians, we've looked after lots of people that you see in the public spotlight that you'd have no idea that they've got these diseases. So it is a truly invisible disease. And they are often struggling with things like pain, with diarrhea, with blood in their poo, with fatigue, and they try to get on with life like everyone else. And so one, we got to think about what psychological impact is that having on them. And we know they have reduced quality of life, particularly with active inflammation. And so it's really important with the psychology to help people through that. And then we also know on the side to that is that we know that stress can cause all these troubles with your tummy, particularly with symptoms-wise. So then the psychology is say, well, it's that vicious circle that comes with it. Look, I'm a bit advocate. I think that most people would benefit from seeing a psychologist at least once in their life. But in terms of particularly in these patients, with really anyone with a chronic type illness, their psychological impact is huge.
So now that we're on this topic, let's move on to your fecal matter transplantation research that you've been working on. So first of all, when did you start this? How did you start it? What inspired you?
Let's start with what it is. So FMT is classic, people may have heard about it, or poo transplants is probably the easiest way of trying to get out the sounding of it. And really the whole idea is that we've said with the microbiome can be triggering the immune system. So what we do is we take that microbiome, take that whole ecosystem from someone who's healthy, a healthy person, healthy donor, through their poo, you take it, and then you do something to it, doesn't matter what you do, and you give it to the patient in some way or form. Okay. So classically, that has been done at the time of colonoscopy. You have a colonoscopy, you take that microbiome, you literally mix it up with some saline, right? With just some salty water, and you put it down through the scope. I finished my specialist training in 2017 and started a PhD at the University of Sydney, seeing whether we can use, instead of doing via colonoscopy, whether we could take that microbiome, freeze dry it, so make it into a powder so it no longer looks or smells like poo, put it in a capsule that's suddenly stable at room temperature, and then suddenly opens up the doors to having capsule fecal transplants. And it suddenly became the ultimate probiotic. It's a probiotic like anyone else takes, but it's the entire ecosystem. And it had been used at a few different centres around the world. There was a collaborator of ours working on using this. And so we thought this would be a good opportunity to test it in ulcerative colitis, so that form of inflammatory bowel disease.
Yeah.
And so we ran the first clinical trial using only capsule fecal transplants in patients with active disease, active inflammation. We could get them into remission, both just not their symptoms getting better, but their bowel actually healing at much higher rates than placebo.
Yeah, wow.
And then we're able suddenly, with capsules, you can give it a bit more longer term. So we showed in this trial that it was safe and feasible to use out to a year. The numbers at that stage were small because it was never been really done before, but show those patients that we could keep well were able to heal their bowel remaining on therapy.
Wow. So to have access to a capsule like this could be potentially life-changing in terms of improving quality of life.
Patients are interested and really keen to say what alternatives or what things can we use maybe in addition to therapy that we're currently on.
Yeah.
We know we've got lots of really great therapies for ulcerative colitis, and that ultimately will impact your immune system in some way or form. But even our best therapies aren't effective in 100% of people. I don't perceive, and working in the field clinically and academically, I don't feel that fecal transplants or other those therapies will ever replace those the therapies we currently use.
Yeah.
But they are perfect complementary. So they perfectly work hand in hand. So not an alternative, as a complementary medicine to whatever therapies we're currently using.
Yeah.
And so if our current therapies work in 60 or 70% of people, can you add this in together and suddenly get that therapy up and potentially reduce the side effects and other things that come with it?
Well, based on that, what are your future hopes, directions? Where do you want this to sort of progress to?
So all the microbiome and fecal transplant research, the majority of it has come from gastroenterology-focused research, given that it's in the gut. And so naturally, a lot of the first data came with the infections in the gut or Crohn's disease, ulcerative colitis. But actually, as we said before, there's so much work coming out about other disciplines and other specialties that are linked with the microbiome. So what we're really interested in, we're trying to say, what have we learned in the gut? And start testing this in other conditions.
Yeah.
And through St Vincent's Hospital in Kinghorn, we've now set up trials in cancer patients receiving cancer therapy and having side effects from their cancer therapy. They will often develop diarrhea and something that looks like colitis. And we've now started the first clinical trial using FMT capsules in this condition now as well, which is exciting. And that's hopefully going to open up the door in some other aspects in oncology. And we're in discussion with a number of other specialties to collaborate with them on some research as well.
All right. Well, I was going to ask you a little bit about philanthropy, if you have any thoughts on that around, with your future direction and research and where you're heading and how that could support or can inform your research.
Philanthropy is really important. Government funding and research funding is so difficult. So I guess philanthropy has a huge role, not just in clinical practice. And we've, at St Vincent's, we've been really well supported by the foundation, and they've helped us set up huge amounts of things for our service, particularly with our managing patients with inflammatory bowel disease. So we've had not only our specialists, which are often covered by the hospital, but they've enabled us to hire dietitians, psychologists, more nursing staff to really support the patients as a whole. We couldn't have done it. And so that's really helped our clinical practice as well. But research is also really, really important. Yeah. And so with the way funding and research goes, to get large government grants, you always need to have at least started and have this kind of rolling momentum and track record to actually get significant funding. And philanthropy can bridge that gap. So philanthropy can get you started, get you that kind of momentum, get these projects off the ground, which you couldn't get without him.
Did you know that the first successful heart transplant in Australia was performed at St Vincent's Hospital? This may be the first time St Vincent's Hospital Sydney has produced a podcast, but groundbreaking research and innovation is entrenched in the DNA of St Vincent's Hospital from its very inception in 1857. From the first successful heart transplant to the first hospital in Australia to perform stem cell transplantation for immune disease, to even opening the first multidisciplinary long COVID clinic at St Vincent's, So much of the hospital's life-changing and life-saving work is made possible by the long-standing generosity of the donors to St Vincent's Curran Foundation, the fundraising organisation for St Vincent's Hospital and facilities in New South Wales. Innovation in medicine has always been the driving force behind progress in healthcare. However, in today's rapidly evolving world, the need for continuous innovation in medicine has never been more critical. We are at the cusp of a healthcare revolution, where breakthroughs in medical research, technology, and treatment modalities hold the promise of transforming the way we prevent, diagnose, and treat diseases. St Vincent's Hospital Sydney has a long history of clinical and research innovation. Its unique position as an integrated clinical research precinct and the vision and ability to deliver bench-to-bedside research-driven care allows us to expand and strengthen leadership in innovative research. Help us to continue to be the driving force in discovery and innovation of healthcare. What will we discover or uncover next? Continue to make a life-changing difference by supporting St Vincent's to ensure world-class medical care and research can continue now and beyond. Visit supportstvincents.com.au today. What if our understanding of inflammatory bowel diseases is just the tip of the iceberg? Enter Dr. Simon Garley, a leading gastroenterologist and the clinical lead of the IBD clinic at St Vincent's Hospital, Sydney. Dr. Simon Garley is not only an expert in treating IBD, but he's also a bit of a debunker of widespread misconceptions about these conditions. So, how has his innovative research really helped to discover new treatments that streamline patient care, but also transform their lives? Prepare yourselves for a revealing conversation that will alter how we view and manage these complex disorders.
I'm Simon Garley. I'm a gastroenterologist at St Vincent's Hospital Sydney, and I'm the clinical lead of the inflammatory bowel disease service at St Vincent's. Took over the service back in 2015.
What inspired you to move into the area of gastroenterology?
As a junior doctor, you rotate between all the different specialty during your internship and your resident year, and it really struck me on my gastroenterology rotations just the spectrum of different disease conditions that you see. And obviously when you're in hospital, what you see are the most severe and the most unwell patients, be that liver disease or people with acute gastrointestinal bleeding. But what was striking were the young patients with inflammatory bowel disease that would come in with severe flares and perhaps even end up needing surgery.
Yeah, absolutely. What kind of new treatments were coming to the foreground at that time?
So this is when we started seeing biologics starting to come into common use, and this was treatments I could see were changing people's lives very quickly. Clinical trials were all underway as well for new drugs, and it was really the start of what we have now as a very different landscape for treating, managing our patients, many of whom are very young and at the prime of their life from a condition that's really debilitating.
So I guess your particular area of focus is IBD, inflammatory bowel disease. How did you develop this particular focus in your area of research and clinical practice?
I guess an area that struck me by how affected young patients were in particular, although it can affect people of any age, but most commonly young people. And until that time didn't have very effective treatments. And there weren't many people interested or subspecialised in treating it, particularly in New South Wales.
Yeah.
Very few, if any, IBD centres. They were just starting to emerge at that time.
Yeah.
And so there was clearly a great need for more people to train, have an interest and subspecialise in IBD. It was clearly a chance to be able to get involved and make a difference. And I'm sitting here today really proud of how far it's come in the last 10 years.
So you mentioned that you were interested in IBD because of the types of patients that were presenting at the time. In your clinical practice, what would be a typical patient that would come to you for assistance?
So quite commonly, and I can think of even a patient that we've just seen last week for the first time in clinic who's had really for probably the last 6 or 7 months terrible abdominal pain, vomiting, losing weight. And that's really brought his life
That's so
to
young.
a bit of a grinding halt from work and study, being able to socialise, go out, eat out,
Yeah.
travel without a clear diagnosis, unfortunately, despite presenting to even the emergency department on at least one occasion. And so this young man's now just had the diagnosis confirmed of Crohn's disease in the small bowel and is about to start on new treatment, having just met yesterday our IBD nurses, our pharmacists and our dietitians soon to really try and address all facets of this condition. And the goal is really to enable him to move on with life without being interrupted by this disease.
Yeah, it sounds like it's a real quality of life inhibitor, really. So you mentioned IBD and Crohn's disease. So from what I understand, IBD encompasses Crohn's disease and ulcerative colitis. What are the key main differences between the two conditions?
Yeah, no, that's absolutely right, Zoe. IBD encompasses both Crohn's and ulcerative colitis. The key differences, and there are many overlaps, I should say, but the key differences are which parts of the gut are involved.
Yeah.
Crohn's disease can affect anywhere in the gut, and we say from mouth to anus.
Yeah.
So esophagus, your stomach, small intestine, large intestine can be patchy. It also involves the whole thickness of the bowel wall, and therefore you're more prone to damaging the bowel and forming areas of narrowing called strictures. It can cause really deep sores and ulcers that can perforate through the bowel wall, causing infections. Ulcerative colitis, on the other hand, is a disease that involves only the large bowel. It starts at the anus and involves a variable distance of the large bowel, the colon, and it only involves the inner lining of the colon. That most typically that presents with diarrhea, often bloody diarrhea. It still can be quite a severe condition, and even in today's day and age, somewhere between 10 and 20% of patients with ulcerative colitis will need to have surgery to remove the large bowel. But those are some of the key differences.
So you mentioned surgery. Is that the only treatment for these types of illnesses that people experience, or are there other options available?
Absolutely. And I guess it's every patient's biggest fear, having surgery.
Yeah.
But, you know, if I speak to my senior 30, 40 years ago, what they remember of the treatment of inflammatory bowel disease were hospital wards full of patients after operations. Nowadays, I'm really happy to see that the number of patients having surgery for IBD in our centre could be counted on one hand. It's fortunately far less common to need surgery with the advent of our really new and exciting treatments. So our treatments there's a spectrum depending on the type of disease and how severe it is and the extent of it, from anti-inflammatory treatments that don't affect the immune system to tablets that suppress the immune system. And then we have our newest agents, the advanced therapies or biologics, which have really been game changers in the treatment of IBD.
So what's a biologic?
So biologics are typically protein compounds or antibodies that are either injected through a vein as a drip or as a self-injection like an EpiPen.
Okay.
And that can be given anywhere from every 2 weeks to every 8 weeks, that target particular aspects of the immune system to dampen down the immune system's response. Because one of the main drivers of inflammatory bowel disease is the immune system is dysregulated or overactive when it shouldn't be against itself, in this case against the gut. A similar process happens in rheumatoid arthritis. The immune system's overactive against the joints. In type 1 diabetes, the immune system's overactive against the pancreas. So inflammatory bowel disease, the immune system's overactive against the gut. And so our treatments focus on dampening down that immune response.
So is this something that you regularly deliver in the clinic, the IBD clinic at St Vincent's Hospital?
Yeah, so we have an infusion centre at St Vincent's Public as well as at St Vincent's Private, where every day we'll have patients coming in and having their treatments if they're being given intravenous, and more patients are being given self-injectable treatment, so they don't even have to come to hospital. They can do it themselves at home. And only in the last 2 years we've been seeing new tablet-based therapy as well, which has been exciting for patients.
This must have really changed the game in terms of patient outcomes, particularly at the clinic at St Vincent's. From what I understand, St Vincent's is a bit of an innovator in this area.
Yeah, no, absolutely. I think we pride ourselves on being innovators, early adopters, really trying to do the absolute best we can for our patients and giving them access to the newest treatments that are available either through subsidised channels of the pharmaceutical benefit scheme, but also clinical trials. Maybe we'll touch on how we use ultrasound.
Yeah, absolutely. Tell me, how are you using ultrasound?
So ultrasound is relatively new in Australia to monitor Crohn's and colitis. Obviously, it's a modality that's been available for a long time for many other reasons. But traditionally, when we look to assess and monitor inflammatory bowel disease, that would typically be with a colonoscopy, and sometimes we might do MRIs. But they're invasive tests. They're uncomfortable for patients.
Absolutely.
It's a day out of action. You've got to drink horrible prep, and it involves an anaesthetic in the case of a colonoscopy, and there are risks of complications. But in 2023, we've moved away really from just having our patients symptomatically feeling better. We really want to drive for that inflammation to be under control. So for there to be no ulcers or no sores in the bowel. But you can't do a colonoscopy every few months to check on that. But you can do an ultrasound. An ultrasound, there's no preparation. Patients will typically come one afternoon without any fasting even, and it's a 15-minute examination to trace the entire large bowel and the small bowel, and you can do that repeatedly over time to monitor the inflammatory process. Our patients often become so accustomed to doing it that they're looking at the screen with me and they can tell when their bowel is looking better.
Amazing.
And so it's really great for having our patients involved in the treatment and seeing the change over time. And so this is something we've been running at St Vincent since 2019, had the support of the foundation in getting our first machine, and we've now got a second mobile machine that we can use for outreach to regional New South Wales as well. And we've managed to get new people on board to do ultrasound, and the service has grown now to be by far the biggest in New South Wales and one of the biggest in Australia. And we constantly have people from around the country wanting to come and train. And so it's been a really exciting innovation at St Vincent's.
That's incredible. I love this element of rural and remote health that you've just touched on. And my understanding is that you also have some collaborations, or you go to Griffith as well, St Vincent's and Griffith. Can you speak to that a little bit?
Yeah, so look, one of the things we know, there was a big national inpatient audit of the care of patients with inflammatory bowel disease all across Australia. And this was commissioned by Crohn's Colitis Australia.
Yeah.
And one of the biggest discrepancies that was seen was that gap between regional and rural care of patients with inflammatory bowel disease versus those in metropolitan centres. We've, for a long time at St Vincent's, Sydney, had a relationship with the whole Murrumbidgee area, so encompassing Griffith and Wagga. And typically patients who needed transfer to a metropolitan centre from those areas would come to St Vincent's in Sydney. And then more recently, St Vincent's has also established the St Vincent's Community Private Hospital in Griffith. So we saw this as an opportunity to get a group of us as gastroenterologists to visit St Vincent's Griffith on a regular basis and look after patients there with gastroenterology needs. And we now have quite a large cohort of people with inflammatory bowel disease that we've taken under the umbrella of our St Vincent's IBD service. So they get access to our nurses and our dietitians and pharmacists as well, so they're not missing out on that quality multidisciplinary care.
So let's talk about some of the rewarding aspects of your work at St Vincent's Hospital, working in the clinic and all the research that you mentioned as well. Can you speak to some of those experiences?
Look, I think really the most rewarding thing is working with patients and seeing the difference that we can make as individuals and as a team in transforming lives. And I can think of numerous patients, but in particular, one patient stands to mind who was a young journalist in her early 20s who really had very difficult to control Crohn's disease. And at one stage, we were having to see her nearly every week or every 2 weeks.
Wow.
Cycling through multiple different therapies on a very regular basis. And it took about 6 to 8 months to find treatments that work. She had lost a drastic amount of weight. And with that close multidisciplinary care, a lot of time and effort from our nurses, all of the doctors. She's now in her mid-30s, married, disease completely in remission, leading an absolutely normal life. You couldn't tell that she had IBD. There's absolutely no impact apart from having to have her treatment every 8 weeks on her life. So that's by far and away the most rewarding thing. The other aspect is really working with great people. So working with our nurses, our dietitian, our pharmacist, and just seeing how they've grown in their own fields and become experts themselves. Similarly, looking at our registrars who come through and our IBD fellows who then go on and do amazing research fellowships, and some of them even come back to St Vincent's now as consultants. So seeing others come through and continue the work moving into the future, this is really the way that we can then have greater reach and improve the care of all patients across the country.
Let's turn our focus to philanthropy now in our discussion, and I'd like you to touch on some of the support you have received in the past and maybe highlight some areas that you can foresee in the future that would be really helpful for the IBD clinic moving forward.
Yeah, no, look, philanthropy has played a huge part for the St Vincent's IBD service. Over the years, we've received a number of very generous contributions. 2 years ago, we had a $1 million donation, and this has really facilitated the growth, or I should say rapid growth, of our service to be able to offer a dietetics service within the clinic, pharmacovigilance service with our pharmacist, really being involved with the monitoring of medications and counselling patients, and really improving all patients' access to the IBD service hotline by having additional nurses. We've also been able to look at innovative ways of delivering our care by using a new software called Crohn's Colitis Care, which we, along with a group of other hospitals around Australia, have developed a specific software to be able to integrate all the different results, our clinical encounters, facilitate patients being able to complete questionnaires to streamline the care of IBD. At the moment, it can be quite disjointed with results coming from different providers. Even within New South Wales, hospitals don't all use the same system.
Yeah.
And so with CC Care, a patient has their file, and if I want to transfer them to Liverpool Hospital because they've moved close to Liverpool Hospital, or to the Mater in Brisbane, or to Royal Adelaide, it's just a click of a button and their entire file has been transferred to their new clinician. So it really allows that continuity of care. It's also facilitated a lot of research in the last 12 months. Probably 20 different abstracts have been presented at international conferences, and so a lot of research is coming out of this, really detailing the quality of care, where the gaps are, how we can further improve care. And one of the nice things is that we've been able to cross-benchmark our care against other hospitals and really see that actually we are doing an incredible job at St Vincent's, and we really are there as the best.
Yeah, amazing. So what are some of your long-term research goals, treatment of IBD moving forward?
Yeah. So one of the great things that we have at the moment are multiple different treatments, but it's also made things really complex.
Oh, yeah?
Like 10 years ago, we only had one or two drugs to choose from. That was simple. If one didn't work, you just used the other. And if that didn't work, well, then you'd have to have surgery. So as horrible as that sounds, it made the decision-making easier.
Yeah.
Now we've got a range of different treatments, and what we need to be able to do is with precision work out what treatment's going to work best for which patient, rather than having to try one. If that doesn't work, move on to the next one. That's still really a gap, and it'd be wonderful to be able to use our understanding so far of the gut microbiome, of genetics, of the clinical profiling, to be able to better personalise care. And really in the next 10 years, I hope that we'd be able to have a bit more precision in personalising our treatment for patients. I think the other area is still about the mental health needs of our patients, and really having structured ways of assessing and managing that, and having the expertise within our clinic to manage it. We know that IBD aside, but mental health conditions and health is a major issue across the general population, and that's only even more within chronic illness like IBD. And so I think that's, again, another main goal. And obviously we're very interested at St Vincent's and have led the way really with microbiome research and fecal transplants and manipulating microbiome, where we're investing a lot of effort and time and leading the way.
Is living with a chronic gastrointestinal disease as daunting as it seems? Let's hear it straight from someone who's actually been there. Meet Annabelle Rogers, a patient treated for ulcerative colitis at St Vincent's Hospital, Sydney. Now, Annabelle's journey really sheds light on the realities and misconceptions surrounding IBD. For example, what are the common myths she encountered? And how did her experience actually defy them? Through her story, we'll gain a deeper understanding of the personal impact of these diseases and the transformative power of modern treatment. Annabelle's tale is not just inspiring, it's a beacon of hope and truth for many. Can you start telling our listeners a little bit about yourself and your involvement with St Vincent's Hospital, Sydney?
Sure. So I have a long history of hospitals. It initially started with me being born 3 months early, and I spent 3 months in hospital getting the treatment that I needed to be here today. But besides that, I have always been very active, love the outdoors, very social, and basically just enjoying life. My involvement with St Vincent's Hospital, Sydney, is quite a unique one. I have ulcerative colitis, and I was referred to see Simon Garley, a gastroenterologist there, for a second opinion in terms of my treatment and how I was managing it, because I was getting constant flare-ups. I was on steroids, enemas, and a few trips to ED, which was not fun, to say the least. So Simon was great, and he told me all about the IBD clinic that they have. I've been a patient there for about a year, and it actually has changed my life for the better.
What happened then? How did your diagnosis of ulcerative colitis come about?
So it all came about, I was in a family holiday in Europe, and I was with my sister sharing a room, and then she told me that I probably should get looked at because my stomach habits weren't normal. So then I went to my doctor, and I'm very fortunate I have an amazing doctor and specialist who said, we can look into this. We did all the tests. They came back relatively normal. And then they said, you can have a colonoscopy now if you like, now or in 40 years. But given your family history, my mum and auntie both have an IBD, Crohn's disease, we can do it now. I went in for my colonoscopy. No one warns you about the prep, but got through that, but it has improved. So I was diagnosed with ulcerative colitis in 2016. I just remember waking up from the colonoscopy and the gastroenterologist saying, something doesn't look quite right, we've sent it off for tests.
Right.
And I was like, oh, cool, he must just mean like the picture wasn't good.
Yeah.
Completely oblivious to everything. And then I went in for a follow-up appointment, and I just remember him saying, you have ulcerative colitis. And I went, what does that mean? And then I literally only remember the words of high chance bowel cancer, and then everything else just went blank. So I have no idea what he said, but I was very fortunate. I remember then calling my dad, and he was like, what? And then I just was really scared because it would be like my mum, because my mum, when she was 14, missed a year of school and had half her intestine out. Even though they were different diseases, my mind just went straight to the worst.
Of course.
But I guess I'm so grateful. So I kind of got over the initial shock of having a non-curable disease, and it's a chronic illness that you live with. But I'm so glad and grateful for the support that I have through my family, friends, and the doctors and the facility that's available at St Vincent's.
So what were some of the challenges that you were faced with?
So I guess it was naivety. It was probably one of the biggest challenges to get over the fact that you can still be relatively young, something not well with you. So I used to always joke with my family that I was the healthy one. Everyone else had stomach problems, and I had the best stomach of them all. So it was quite a...
Did you jinx yourself?
I think I might have jinxed myself, but that's okay. But I had just abnormal symptoms, which I thought were just normal. I had no other context to really go off. I thought everyone was like that. So I had severe bloating. I remember sending it to my friend that was pregnant at the time. She was like 3 months, and she was like, you look more pregnant than me. And I was like, oh my gosh, your stomach can just really bloat and become really painful. Then I also had abdominal pain, bleeding, and then urgency to pass. So there were lots of challenges, having to always think, where am I going to be? Like, what can I take to make myself feel better? Because you don't want to miss out on life and your social occasions. I've really been trying to reframe and retrain myself, which I feel like this year I have a bit. So what's that? 8 years on, understanding that it's okay to ask for help. And if you don't feel well, you don't have to keep pushing and living through the pain. There is ways of support.
No, absolutely. So I guess you found your way to St Vincent's Hospital.
Yes, a long rabbit hole, but I got there.
Eventually. So when did you start going to St Vincent's?
I'm a bit of a frequent traveller to the hospital just because I'm a bit accident prone. But to my ulcerative colitis, I went December 2022, or maybe November 2022, I had a meeting with Simon, and he just really educated me, gave me a massive understanding and great support in providing and telling me more and educating me and giving me the power to really understand what ulcerative colitis is. And then he recommended me and referred me to the IBD clinic. So that is amazing. I go there every 8 weeks. I get an infusion for my stomach. Works its magic. So I'm very fortunate. And I also take daily medication, which I may be able to get off in the next year, they said. So that also reduces and soothes the pain, but also reduces the chance of bowel cancer. And then when I have the infusion, they also do my blood tests to ensure that all my markers are okay. And then if there's anything wrong, then when I have my gastroenterologist appointment every quarter to 6 months, then we'll talk about how I'm feeling, the treatment and ways of moving forward. I think I'll be a patient at St Vincent's, the IBD clinic, for life, unless there's a cure. But I'm very happy and very grateful for the amazing support and guidance that they give day and night.
Yeah, it sounds like a very supportive team that you've been working with all these years to treat your ulcerative colitis. I'm sorry that happened to you, poor thing.
Oh, that's okay. It's amazing that St Vincent's offer such a brilliant clinic. So I can call someone and say, I've got a cold or I've got this, can you please explain more? And then they'll always get back to you and give you guidance. And even if you're getting your treatment, you want to ask a question, they're always there to help and educate. And it's amazing. One big happy family.
Is that why you prioritised seeking treatment at St Vincent's over other?
Yeah, so Simon really sold, Dr. Simon Garley looks after the IBD clinic, and he was telling me the benefits, which I also was struggling a bit with when I had my gastroenterologist. You have to wait to see them, just like any specialist. They might be doing treatment. They could be out for weeks on end. And so it's really hard to get in. And when you urgently need help and feeling uncomfortable and in pain, you want it resolved right there, then and now.
Yeah.
So I was very fortunate that I then found and discovered IBD clinic, and then the service that they've got a nurse all the time on call. You can email them, you can call them, so they're always there to help. We'll be able to help those in need.
Amazing. Well, it sounds like St Vincent's Hospital really did change your life.
It did. It did. I was speaking to a gastroenterologist in my appointment the other week, and he said, think about your life 6 months ago and to now, where you are now, what would you prefer? And I was like, I don't want to go back to that life.
Yeah, of course. No, that's amazing that you can feel that level of comfort and reassurance, and that it's changed and improved so much as well. What message would you like to share with others who also live with IBD?
It's actually okay to ask for support, and you don't really need to suffer in silence. But also, if something doesn't feel right, keep investigating, keep asking. And also try and find a community or a group that you can talk to, whether they have IBD or not. The other day I went to a lunch and 4 of us so happened to have IBD. So I definitely think there's more prevalence and awareness of it now. Find a specialist that works for you. Identify your triggers or things that might upset you, but also understand that it's okay if you do get carried away or have a bit too much fun. If you, for example, eat too much junk food, or if you're drinking too much, or if you're stressed or you're not sleeping well, understand that's only normal, it's only human. But what you can do is then put a line in the sand and start again and just say, okay, what can I do to nourish my body? If it's sleep well, drink water, relax. I might not be able to change everything, but I can just control one thing at a time.
Thank you for joining us on Discover St Vincent's. If you would like to find out how you can support pioneering research and innovative treatments, visit supportstvincents.com.au. Your support can make a real difference. Together, let's shape the future of healthcare for all. Until next time, I'm Zoe Callister-Hakewell.